allow everyone to come into the webinar. This is day 3 of the Critical Care Bootcamp. Thank you so much for joining us. First, just want to say that we are completely overwhelmed and very happy about the support that we've received from all of you participants. Thank you. It's been a really great experience building this community around providers trying to improve the care of critically ill patients. So we're very grateful to you. I'm personally very grateful too to my team for coming together and putting together this nice webinar series. This is the Critical Care Bootcamp. This is a 5-day series covering the topics that were selected by you. So the most highly requested topics that we need to discuss to improve our care of critically ill patients. So we talked about stroke and traumatic brain injury already. Today is day 3, so we'll be talking about diabetic ketoacidosis. So before we get started, we just want to remind you of a few things regarding etiquette. We want to make sure that this is a professional and respectful environment. So please, if you disagree with something, do so with kindness. Please also try to keep our WhatsApp group professional and relevant to these topics in this group. We love building community, so we encourage you to use the chat function at the bottom of the screen to introduce yourself and say hello. However, please use the question and answer function to send questions to the panelists. If you notice that this session is being recorded, your attendance is your consent to be recorded, so thank you. We do want to build some professional development opportunities. If you are on the session for 45 minutes or more in total, then you should receive a certificate. The certificate will be sent to the name and email address that you used upon registration, and it should arrive to you between 7 and 10 days at the latest. So for certificates of attendance, you need to be on for 45 minutes. They'll be sent to the email address provided, and they should arrive after the webinar. Unfortunately, we do not have certificates available for independent online study currently, but it's something we're looking into to see if we can provide at a later date. All materials will be hosted on the Learning Resource Center. This is where you find the slides. This is where you can find the video recordings. This is where you can find the resource library. And this is where we will post the frequently asked questions that you send to us. You can use this QR code, and we'll also put a link to the LRC in the chat for you to access. Closed captioning is available at the bottom of the screen on Zoom if you need to use that to follow along. The speakers will be using English. We have a WhatsApp group. Many of you have already joined. You can use this QR code or the link here to join the WhatsApp group. And with that, I'm very pleased to introduce our team of panelists today. This is the Diabetic Ketoacidosis talk. And our speakers are from around the globe and from multiple different specialties. So I'm thrilled to introduce to you first Dr. Jean Dedue Singilacavo, something like this. Sorry, I practiced many times your last name, and I apologize. I know I did it wrong. Dr. Jean Dedue is a friend of mine and a senior resident of anesthesiology at the University of Rwanda, studying anesthesia and critical care. He's known by his department for his excellent skills in teaching. Dr. Sami Ben-Jamil is a surgical critical care fellow at Stanford University. He earned a combined MD and MPH from the University of Texas in 2016. And it was a Fulbright Scholar in 2015. He's developed many impactful community health programs in Burkina Faso, so we're grateful for his presence today to contribute to this conversation. Dr. Rebecca Walker is a clinical associate professor of emergency medicine at Stanford University. She's worked for many years in global health and also has expertise in medical ethics and organizational leadership. And Dr. Andrea Comiskey is an emergency medicine physician and critical care medicine fellow at Stanford University. Her current interests and projects include global health bedside and virtual education with a focus on emergency medicine and critical care in limited resource settings. Dr. Comiskey is the co-lead of this project and co-PI, and I'm incredibly grateful to her for helping us lead this project, the Critical Care Bootcamp. And with that, I want to turn it over to Dr. Benjamin. Thank you.
Thank you, Dr. Crawford, for the introductions, and I will share my screen. So welcome, everyone. Thank you so much for coming today. As mentioned, my name is Sam Benjamin. I'm a fellow at Stanford, and Dr. Sengun Cabo is a anesthesia resident for the University of Rwanda. And we're very excited to together be able to present this bootcamp presentation of diabetic ketoacidosis and hyperglycemic hyperosmolar state. So quick outline of the presentation. So we'll have a quick introduction. We'll discuss the pathophysiology of both of these diseases. We'll have a short case study that will follow throughout the presentation. And we'll discuss the differences between diabetic ketoacidosis and HHS, and then as well some management strategies. So just begin with some context. So as you know, diabetes is a chronic condition characterized by inadequate insulin production or use. Both DKA and HHS are life-threatening complications of diabetes. While relatively they're unusual, in 2014, 8.5% of adults had diabetes. So of adults in the United States had diabetes. So you can imagine that there's still a pretty high chance of encountering one of these conditions in your emergency room. Importantly, diabetic ketoacidosis itself affects about 2/3 of people with type 1 diabetes and 1/3 with type 2. So really quick, the pathophysiology of diabetic ketoacidosis. So this all begins with a relative, almost complete insulin deficiency. So there's a few things that happen around the same time. You have your decreased glucose uptake, which is going to cause already a degree of hyperglycemia within your blood. And then at the same time, because you can't uptake glucose into your cells are essentially in a state of starvation. So in order to find alternative sources of energy, the body is going to engage in lipolysis and proteolysis. The end result of this is that you're going to get free fatty acids, ketogenesis, which is what leads to acidosis and diabetic ketoacidosis. And then the other part of that is you're going to start stimulating the production of glucose because all the body knows is that you're not getting enough glucose into the cells. So it's going to try to create more glucose because it thinks it's just not enough inside the body. So then this causes even worsening hyperglycemia, which eventually is going to cause an osmotic diuresis and severe dehydration. So,
Dr. Benjamin, may I ask you, sorry to interrupt, do you mind slowing down just a little bit for our non-native English speakers, please?
Oh, sorry about that.
Thank you.
Okay. So acidosis and dehydration are two hallmarks of the pathophysiology and diabetic ketoacidosis. As I touched on a little bit, some of the key points of this pathophysiology, insulin deficiency keeps your glucose out of the cells, leading to both hyperglycemia and starvation. The cells experiencing this starvation start stimulating gluconeogenesis, so then you get worsening and aggravation of your hyperglycemia. And this severe hyperglycemia then causes dehydration, and then which causes some of the end effects of terms of altered mental status. Because of the almost complete deficit of insulin and diabetic ketoacidosis, you get ketosis formation and acidosis, whereas in HHS, you have some insulin, so you do get a little bit of, you don't get the ketosis and lipolysis that's going to lead to acidosis, but you do get actually a more profound hyperglycemia and a more profound state of dehydration. This is just a graphic illustrating again the state of diabetic ketoacidosis. So without insulin, the glucose cannot be processed by the body. Your liver primarily is going to then start accumulating more production of glucose. As the body needs to find an alternative source, it breaks down fat, which leads to more glucose and more hyperglycemia. And then those ketones are transferred into the kidney and bladder, which causes an osmotic diuresis and more dehydration, which may then even worsen your acidosis. This is a graphic illustrating the difference between ketoacidosis and hyperosmolar or hypoglycemic state. As you can see, their initial inflection point is having to do with decreased insulin, but whereas DKA has an absolute or near absolute deficit of insulin, HHS is relative enough to where you're not breaking down free fatty acids and you're not having ketone body production and the resulted acidemia. However, because you still are in a relatively insulin deficient state, and your body will continue to engage in gluconeogenesis. And this actually leads to more profound hyperglycemia than what you see in DKA, which in turn leads to a more profound dehydration than what you see in DKA. So while there are many similarities between both of them, and while both of them do have dehydration, the hallmark of HHS is an extremely profound dehydration and a higher glucose, whereas in DKA, yes, you do have your dehydration and your hyperglycemia, but you also have the acidosis. Critical features of DKA, these are all sequelae of the acidosis and the hyperglycemia and the resulting dehydration. So you'll have tachycardia and eventually potentially low blood pressure. The acidosis and dehydration can then cause altered mental status. Something you all may have heard is the fruity odor from your breath from the ketosis. That is also a pathognomonic sign of ketosis. The Kussmaul respirations from the acidosis, and then nausea, vomiting, and abdominal pain, as well as the polyuria. Severity of DKA can be separated based on the degree of acidosis, as well as your bicarb deficiency, anion gap, and your mental status. Your mental status, of course, is it can be as bad as entering a state of coma, whereas your anion gap can even be greater than 12, with pHs even going lower than 7. Compared to diabetic ketoacidosis, HHS is more gradual in onset. It does have the dehydration, though more severe, alter mental status from the severe dehydration. However, one distinguishing factor is that HHS actually has less common side effects of the nausea, vomiting, and abdominal pain that you see in diabetic ketoacidosis. This is a table summarizing the difference between DKA and HHS. So one thing to look at is the rapid onset of DKA, hours to days, whereas HHS is days to weeks. The glucose level, while both are in hyperglycemic states, you can see in HHS, it's oftentimes even greater than 600 or more. There's no ketones in HHS, therefore no acidosis, which you do see in DKA. Another hallmark of HHS is you will see an increased osmolality in the blood, as well as along with severe dehydration. Another distinguishing factor is the age. DKA is more common in younger people, which is consistent with its prevalence with type 1 diabetes, whereas HHS is more common in elderly people. which is more consistent with patients with type 2 diabetes. Precipitating events that can cause both DKA and HHS, most of the time, what has actually precipitated it is unknown, though the most common known precipitating factor is infection, namely UTIs. Non-compliance with treatment, patients that have run out of their medications, run out of their insulin, and unable to obtain more, as well as new diagnoses of previously unknown type 1 diabetes until patients present in a state of DKA. And then other stressors on the body, such as ischemic states, alcohol or other drug abuse, and pancreatitis. So we're going to briefly present a case. So
Hey,
you can
Sammy,
imagine yes.
can we take a quick moment? There's a question in the chat that maybe we can address now. And
Okay.
so Hasina asked, how do you manage a patient with high RBS above 30 in an ambulance? And so RBS would be blood sugar. So extreme hyperglycemia. What would be your recommendations? And this question is open to both you, Jean Nadeau, and Dr. Walker as well.
So the question is if the patient is recognized that they're hyperglycemic in the ambulance. I think it depends on what resources are available at the time. In general, the very first thing you want to do is aggressively rehydrate the patient. So I think in the United States, the ambulances are able to do that pretty quickly. However, as far as I know, there is not necessarily any insulin available on an ambulance in the United States. So I would say that realistically it would be focusing on aggressive rehydration rather than actively treating the glucose until they arrive to the hospital. In addition, there are a few caveats to starting to treat some of the glucose and electrolyte abnormalities that do require close monitoring, or else you can cause yourself to the patient to be in states with profound hypokalemia and eventual hypoglycemia. So that treatment will likely be deferred until they're in a more appropriate setting.
Thank you, Dr. Benjamin. And I'll just add to that, I'm an emergency medicine physician. And so one of the first things that we do, even in the emergency department, is to give aggressive fluids. And that is much more important to do quickly than insulin. We're a little bit more careful about when we're giving insulin, just to make sure that we're giving the right amount. And we help teach paramedics and EMTs also in different places, Nepal, India, and around the globe. And so, IV fluids in that early first responder time is really important. And people will often have a lot of mortality from the dehydration of these hyperglycemic states, more than just their hyperglycemia itself. It's really the dehydration that's super important. So that's a great question. Thank you.
And then another question that I think is relevant to the material that you just covered. Alexander Ampofo asked, what are the risk factors for DKA? And so if you could go over those perhaps a little again, and maybe slower this time, that would be lovely.
No problem. So most of the time, the exact reason for what has precipitated a DK event is not able to be determined. However, when the precipitating factor is known, it's usually infection. And the most common type of infection associated is a urinary tract infection. On a secondary, or oftentimes hand in hand with that, can be where patients who are not taking insulin, or new diagnosis of type 1 diabetes. Diabetic ketoacidosis is most associated with younger patients, and oftentimes younger patients are unaware of their diagnosis of type 1 diabetes until they present to a checkup, or in a more serious manner if they present in a state of diabetic ketoacidosis. So these patients wouldn't have been taking insulin because they may not be aware of their type 1 diabetes diagnosis. And then in general, other stressors such as ischemic events or substance abuse.
Thank you, Dr. Sami. Also, what I can add to this commonly precipitating risk factor for DKA and the HHS, when you go to the infection factors, they are like UTI, as he said, but also when a patient is having like appendicitis, cholangitis, also can precipitate a DKA. In addition to that, when you go to non-compliance with treatment, if a patient is not complying to medication or taking inadequate dose of the medication, also this patient may have the DKA. In addition to that, we can know it from the history if the patient is a drug abuser or if the family report that the patient the drug is being only given by the family, so we can start to suspect the uncompliance to treatment. And diagnosed DKA is also common, especially in our developing countries, where people decide to consult the hospital when they are ill or when they are not feeling well. Also, for other stressors, when you go to things like MI, which may be acute alcohol consumption, pancreatitis, also some drugs, and even pregnancy for ladies, a pregnant lady pregnancy may induce the decay. So the precipitating factor are many. Thank you.
Great, thank you so much. That was very helpful. Dr. Kaminsky, any other questions at this time?
No, thank you.
All right, thank you. All right, so as we progress through the rest of the presentation, we're going to follow along a case. So this, if you can imagine, is a 15-year-old female presenting to your emergency room by ambulance. Her mother states that she's had lethargy, nausea, vomiting, and decreased level of consciousness for about a day. The people on the ambulance, the healthcare workers in the ambulance tell you that just from the trip from the house to the emergency room, she's been harder to arouse. So as she arrives to the emergency room, on her vitals, you can see that she does have a heart rate of 115, so she is a little tachycardic. Her blood pressure is normal, but she also has a respiratory rate of 33. In general, on her appearance, you can tell that she is unwell, lethargic, she is difficult to arouse, and she also has vomit on her face and on her shirt. A GCS score is obtained of 5, and other significant lab values are a glucose level of 418. There are positive ketones in the serum, and a relative hyperkalemia, as well as acidosis and decreased bicarbonate on the arterial blood gas. So what is the first step? And at this point, if we can, we'll be able to launch a poll to see if you guys are able to give your responses, and then we'll see how everyone responded. So what would your initial management priority be for this patient? Would you A, administer IV insulin, B, begin IV fluid resuscitation with normal saline, C, administer IV sodium bicarbonate, or D, prepare for immediate intubation? Dr. Crawford, do I have to go through it? Or?
I can end the poll whenever you want to stop it. Do you want to stop it now or give them another minute? Or
sure, we'll give another
about 30 more seconds.
30 seconds.
Okay, great.
Thank you.
Can we allow people to read again the question?
Sure. Yes, I'll read the question again. What would your initial management be for this patient? So a 15-year-old girl who's presented with altered mental status and elevated blood glucose, tachycardia, and acidosis. Would you give IV insulin? Would you begin IV fluid resuscitation? Would you administer sodium bicarbonate, or would you prepare for intubation?
Okay, I ended the poll. We'll share the results now. Most people want to start fluid resuscitation with normal saline.
Okay, so something to consider. The answer that I have is actually D, which was to prepare for intubation. And I'll go back to the initial case presentation. So while you're right, this is, everyone was aware, I think, that this is diabetic ketoacidosis. I gave a few concerning signs. One is that even in the ambulance, that she had been harder to arouse throughout the trip. The second is that she, on arrival, is difficult to arouse with vomit on her face and her shirt, with a depressed level of consciousness and a GCS of 5. So while you're right, everyone who answered B is correct. You would, for the treatment of diabetic ketoacidosis, you would begin fluids. This doesn't mean that we should diverge from our assessment of protecting her airways. So that was why for this question, preparing for intubation would be the first step.
I will say
All
a
right.
caveat to all of this as well is that in reality, both are correct because you are going to prepare for intubation, as Dr. Benjamin was saying, but at the same time, someone is also working on fluid resuscitation. So both are correct, but Dr. Benjamin really wanted to highlight the concern for her airway here, which is something to just be mindful of. And some of the comments in the chat were like A, B, C, D, E for sure, always airway, breathing, circulation.
Yeah, it was sort of like a trick question because exactly like you're saying, in reality, all these things generally are happening at the same time. But for test question purposes, this is how they'll try to trick you. At least in the US, they try to. All right. For our next question, what would the
I just want
next?
to also highlight, if I may, sorry, this is Anna Crawford. I want to highlight that Dr. Comiskey's comment really highlights that this is a team effort and that you often need more than one bedside provider to manage this. So once you identify a patient that needs time critical care, whether it's DKA, whether it's stroke, whether it's traumatic brain injury, any of these time critical topics, you need to call for help and mobilize resources that become available for these patients. So very good points about one person can be preparing to the intubation while others are starting IVs and starting IV fluids. So those are great points. Thank you.
Thanks, Dr. Crawford. All right, so after the patient's intubated, her airway secured, what would be the next management step or the next priority in management step? Would it be to then give IV a 50% dextrose IV? Would it be to start IV infusion of insulin? Would it be to give IV fluid resuscitation with normal saline or sodium bicarbonate for her acidosis? And I think we can start the poll again. So A again would be to give an amp of D50, a 50% dextrose. B would be to start a continuous IV infusion of insulin. C, again, IV fluid resuscitation. Or D, administer sodium bicarbonate for the acidosis.
We'll pause here for a couple seconds to let 1,000 participants take this poll. We have over 1,000 viewers on this webinar. That's pretty exciting, from all over the world.
Okay, I'm going to end the poll now at 1 minute and 30 seconds. Okay, here's the results.
Great. So most people answered, again, either fluid resuscitation or normal saline, which is correct. So the next priority after securing the airway, with again the caveat of saying that these are usually happen in conjunction, is to begin fluid resuscitation. Remember, one of the thing that makes diabetic ketoacidosis and HHS so dangerous is the profound dehydration. So beginning fluid resuscitation is of the utmost priority before even treating insulin or treating the hyperglycemia with insulin.
I have one comment. Hello?
Yes, we can hear you. Go ahead, please.
I have a comment for question 1. This patient who is in DKA, who is having altered mental status with a very low Glasgow scale of 5, and even for others, like the question asked previously about a patient who has high glycemia and who is in the ambulance, when this patient is in severe hypovolemia and is having a low Glasgow scale needing airway protection, doing intubation, you need to be curious. You need to be more concentrated. The reason I'm saying this, because if the patient is severely hypovolemic and you want to intubate that patient, one, by giving medication, like those medication you use like propofol, even opioids, thiopentol, all those medication will cause cardiorespiratory depression for a patient who was in a hypovolemic shock or who was severely dehydrated. This patient may have hemodynamic collapse during airway management. So you may need to use placers and to give fluid bolus before that intubation. In addition to that, remember the patient in diabetic ketoacidosis, the acidosis they have rapid and shallow breathing, the Kussmaul breath. And when you give medication, those compensatory mechanisms are lost. And if those compensatory mechanisms are lost, the patient will be more acidotic. You will be worsening the acidosis. So if the patient was having a low GC-SO4/5, was very hypovolemic, and you are worsening the acidosis, you have the risk of causing cardiac arrest during airway management. So you need to mitigate this risk of worsening the acidosis. In addition to that, if this patient is like that, you need also to think of possible aspiration, because it's an emergent airway management. So you may need to do gastric ultrasound and see if the stomach is full, or insert a nasogastric tube or give antiemetic. So we need to be more concentrated. We need to be as a team to manage this airway to prevent emergency or to prevent cardiovascular collapse during this intubation. Thank you, Dr. Sami.
No, thank you so much. That was excellent, and you really highlighted the complexities of these scenarios. And this isn't certainly this is not just a straight shot in terms of innovation, and just the act of innovating in terms of induction and in the medications and the insertion of the endotracheal tube is going to cause a lot of potential complications in terms of, as you mentioned, cardiovascular collapse. And this again touches on the importance of working together as a team, a lot of these things happening in conjunction with each other, and close monitoring. And beyond that, just anticipation of potential negative effects that can have as you start to intervene on this patient. Thank you so much. That helps a lot in terms of giving insight. All right. I think we'll begin. I'll hand it off to you now.
Yes, can you project for me?
Yes, I'll continue sharing and moving along for you.
Okay, thank you. So we are starting with the management of patients with DKA versus HHS. So if I start with the patient who has DKA, as Dr. Andrea, even Dr. Walker was saying about it, we have to start by the ABCE approach. We have to do the primary survey. If the patient needs the airway management, we have to do it. And also we have to assess the degree of dehydration. So to make it clean, I wanted to make some objective for this management. The first objective we have is to do primary survey doing ABCD. After that, we have to do the collect fluid deficit. The patient will be having different degree of dehydration, so we have to collect fluid deficit. The second objective we have to do to repress potassium, because patient with DKA, most of them, they have the hypokalemia, so we have to correct this electrolyte imbalance. The third objective, we have also to stop ketone production. By providing insulin, we stop the production of ketones. And also the fourth objective, we have to treat the underlying cause. We have seen that patients with DKA, HHS have different underlying cause. If the underlying cause was a surgical emergency like an appendicitis, we have to start thinking about it as early as possible. So we have four objectives: to collect fluid deficit, to repress potassium, to stop ketone production, and to treat the underlying cause. So if I start by the first objective of fluid deficit collection, the first question will be, why do we need to do the fluid deficit collection? Why do we need to collect dehydration? So by collecting dehydration, we restore the intravascular volume. If a patient was in shock and you give fluid, the intravascular volume is restored. That's the first one. Also, by collecting fluid deficit, we improve organ perfusion and the renal function, of course. So if the patient was in a hypovolemic shock, grade 4, or yes, if the patient was in a hypovolemic shock, it will end up having the prerenal AKI. So, but by giving this fluid, we improve organ perfusion. If a patient was having like altered mental status, Glasgow coma scale, less than 15, by giving fluid, the GCS will also come up and the patient will become awake. Also, the hypovolemia itself, dehydration, causes insulin resistance. So when you collect the fluid deficit, you reduce insulin resistance, and the body started to use the insulin which is there. That's why for a patient with DKA, which is mild or moderate, as Dr. Sami presented to us, you can give fluid, and after a few hours, the glycemia decrease without giving insulin. So the fluid deficit collection reduces insulin resistance. So to do it, it is simple. The first thing you have to do when a patient is in DKA and they want to give fluid, we press 2 large bore IV line. After pressing 2 large bore IV line, then you start to give fluid. If you are not able to give large bore IV line, you can give a central line, but central line is not mandatory while treating a patient with DKA. And after that, you assess the degree of dehydration. If the patient is in shock or is having severe dehydration, what to do? We start by giving fluid, just crystalloid. You can start with normal saline or Ringer's lactate, 1 to 2 liters per hour. You collect the shock and severe dehydration. And after collecting that shock, after collecting dehydration, giving 1 to 2 liters per hour of the for that patient. And once the patient is evolemic, I can say, you start giving normal saline, I mean 0.9 normal saline or Ringer's lactate based on collected sodium values. So to clarify this, if a patient is in shock or is having severe dehydration, you don't need to calculate the collected sodium. You give the fluid you have to collect that status of shock or severe dehydration. But once you have evolemia, you start to calculate the collected sodium. You can use Medicalc to calculate the collected sodium. So when you find out the collected sodium is high or normal, it is recommended to use half normal saline to give the IV fluid. And when you find it low, the collected sodium, when you find that it is low, you can use normal saline or Ringer's lactate at the rate of 500 ml per hour. Yes, at the rate of 500 ml per hour, and until your patient is doing well. And also, in addition to that, when you are giving IV fluid and you found your patient, because in DKA, even if we start by fluid resuscitation, we measure glycemia every 1 hour. So as we measure glycemia every 1 hour, when you find out the glycemia is below 250 milligram per deciliter, you don't give half normal saline or Ringer's lactate. At that time, we need to add a dextrose solution. It is recommended to use dextrose 5% plus half normal saline. And when the patient is evolemic, you can give at 200 ml per hour. That is okay. Yes.
Dr. Singhi,
Yes.
a lot of questions about using normal saline versus Ringer's lactate, lactated Ringer's, or other balanced salt solutions. Can you tell us a little bit about your thoughts on which one is better and which one you would select to use in a DKA or HHS patient?
So the patient who is, I started clarifying, if the patient is in shock, I use the solution which is available on my press. I start to think about which one to use when the patient is evolemic, because they report overuse of normal saline will result in hyperchloremic metabolic acidosis. So we can use Ringer's lactate when the sodium, collected sodium is normal or low. But when it is high, it is advised to use half normal saline. So it is a discussion, but you use what is available on your press, first of all. And if you use much normal saline, you have to think about hypercholemic metabolic acidosis, which you need to collect before stopping insulin infusion. Thank you. Hello?
Some are asking if Ringer's lactate will worsen glycemic control. Can you comment on that?
Ringer's lactate will worsen glycemic control.
That is a question.
It will.
My answer
So-
is no. I don't think it worsens glycemic control because there's no glucose within lactated Ringers. So lactated Ringers will not worsen glycemic control.
Yes, thank you.
The other thing to think about is if you're going to resuscitate someone with large volumes of normal saline, eventually you can get a hyperchloremic metabolic acidosis. So that's also a reason that Ringer's lactate could be the preferred fluid for if there's copious amounts of resuscitation.
I really like your point that you use the fluid which is available, because I think there's still studies being done to decide when to switch and when the nuances of adding different types of fluid. But very importantly, dehydration is the main thing you're trying to treat, and so any fluid that is isotonic is key at the beginning.
Thank you. So let's go to our case. After giving fluids, the vital sign, the heart rate, become 105 per minute. The blood pressure become 125 over 18 millimeter of mercury. The respiratory rate 28. The blood glucose was 369 milligram per deciliter. Serum potassium was 5.2. Serum sodium was 132 millimole per liter. And the pH was 7.118. What is the next management step? Start insulin infusion, administer IV potassium, continue fluid resuscitation, administer IV sodium bicarbonate. So you can press the pause and we answer the question. Dr. Sami?
We'll give maybe another 30 seconds.
Okay. Yes.
Okay, here are your results.
So the answer is A. we need to start insulin infusion as we have given IV fluid. The potassium is above the recommended potassium level because they recommend when potassium is above 3.5, we are allowed to start insulin infusion. So we can now start the insulin infusion. Thank you. So the next small question. The vital sign, heart rate, become 95 per minute. The blood pressure 120/75 millimeter of mercury. Respiratory rate 22 per minute. The mental status improved. Now it is Glasgow Coma Scale is 11T. The blood glucose is 189 milligram per deciliter. Serum potassium is 4 millimole per liter. And serum sodium is 135 millimole per liter. The pH is 7.25. Bicarb is 15. What is the most appropriate next step in the management of this patient? I think we discussed on this question on the previous slide. Can we look on the answer?
Let's give them 10 more seconds.
Oh, thank you.
There's 1,000 people. Remember, we're trying to manage 1,000 people. So maybe just a little generosity with the timer. But okay, we can end it now. I'm trying to give them 1 minute 30. Okay, here are your results.
Thank you. So I see a big number has answered it correctly. As we discussed in the previous slide, when the glycemia serum glucose level are below 250 milligram per deciliter, we have to add dextrose to make sure that we don't go the serum glucose below 200. So that was the answer B. Reduce infusion rate and add dextrose to IV fluid. Thank you. So the first objective, we finished it. Collection of fluid deficit and how to give fluid. We saw it. We are going on the second point, collection of the electrolyte, especially the potassium deficit. Hyperkalemia is often present, but it resolves quickly with the insulin infusion. And remember, serum potassium is high, but total body potassium is low because of shift. So the potassium may be low because of intracellular fluid shift. When the cells are shrinking, also the potassium passively will shift from the intracellular to extracellular. I mean intravascular, yes. Also, the insulin deficiency. We know insulin causes potassium to move intracellular. But if there is insulin resistance or insulin deficiency, the more potassium will stay intravascular and the person will be seen with high potassium values. So to collect this potassium deficit, or to collect these potassium values, they recommend us, one, if potassium is less than 3.5, some references say potassium less than 3.3. There is a difference of 0.2 millimolar per liter. They say don't give insulin when potassium is low. Start with potassium collection, and you can give 20 to 40 milliequivalent per liter per hour of potassium chloride. To specify this, if you want to give high values, high amount of potassium, more than 20 milliequivalent per liter of potassium, it is required to give like 20 milliequivalent per hour in one large bore IV line, and also give another 20 milliequivalent per hour in the another bore IV line. But if you want to give them in a single line, we need to press a central line so that to prevent the irritation to peripheral vessels. So you can give 20-20 on peripheral line, or give the whole 40 milliequivalent per liter per hour in the central line. And now you can resume insulin infusion when the potassium is above 3.5. And when potassium is between 3.5 to 5.3, there are like two parts. When the potassium is between 3.5 up to 4, you can give 20 milliequivalent per liter of potassium chloride per hour. And when potassium is between 4 and 5.3, you can give a small amount of potassium, just 10 to 20 milliequivalent per liter of potassium chloride. And they recommend us, if potassium is above 5.3, there is no need of giving potassium supplement. You just check potassium every 1 hour, every 2 hours, yes. The need of checking potassium every 1 hour is we need to check potassium every 1 hour when you are giving large amount of potassium infusion. For example, patient with hypokalemia less than 3.5, we are giving 40 milliequivalent per liter of potassium chloride per hour. If you pass a long time infusing such amount of potassium, you will end up having severe or even deadly hyperkalemia. So if you are giving high potassium, you need to check potassium every hour. But if you are giving less than 20, you can check every 2 hours, that is okay. Another recommendation says that when you check potassium values and you find the patient is having potassium greater than 5.5 with EKG change of hyperkalemia, you need to stabilize the myocardium by giving calcium bicarbonate. So if potassium greater than 5.5 with EKG change relative to hyperkalemia, you have to give calcium bicarbonate. And if you find a potassium greater than 6.5, even if the ECG is normal and you trust your lab, of course, you need to also give calcium gluconate to stabilize the myocardium. That's what I can say on the potassium supplementation.
Dr. Singa,
Yes.
we've had several questions in the Q&A about the choice of fluids and concern because lactated Ringer's or Ringer's lactate contains potassium. you've also mentioned that initially the potassium on lab can be either high or normal, but that the total body potassium is low. Can you
Yes.
talk a little bit more about the choice of fluids, particularly Ringer's lactate, and how that interacts with potassium as you start to treat the diabetic ketoacidosis?
So,
Is there a concern for Ringer's lactate, since we've told the audience that is our fluid of choice if available?
so when I am collecting potassium, if I don't have hyperkalemia, as the Ringer's lactate contain potassium, I can give it. If I don't have hyperkalemia.
I would argue in early DKA, even with the hyperkalemia, as you begin to fluid resuscitate the patient, as you begin to correct the acidosis, and as you begin to give insulin, the potassium will go down so that you can still use the lactated Ringers, because the initial lab potassium will be high, but it will go down very quickly as soon as we start fluids to correct the acidosis as well as the insulin infusion. Do you
Thank
agree?
you. I agree.
Okay, Marcosi.
The other thing I'll mention is that lactated Ringers, while it does have potassium, the concentration is only 4 millicolins per liter, meaning an entire liter of lactated Ringers would only raise your serum potassium by 0.04. So it's a pretty insignificant amount of potassium that shouldn't raise your serum levels.
Thank you, Dr. Sami. So we go to the other point, collecting the hyperglycemia. Yes, collecting the hyperglycemia also is important, as we saw in the objective, because by collecting hyperglycemia, you collect the acidosis. And they recommend us, when we have a lower values of potassium, we can start insulin by 0.1 unit per kg as infusion. I want to be clear on this point. If the patient is not critically ill, if the patient is not acidotic, very acidotic, and if we have our medication ready on the table, we have to emphasize that we can immediately start the insulin infusion at 0.1 unit per kg and keep measuring glycemia every 1 hour. But if the patient, if you don't have insulin on the table ready for use, you can give 0.1 unit per kg. I mean, you can give 10 international unit bolus and go to such other amount of insulin. So they say, don't delay to start insulinotherapy because you are collecting materials. You can give that bolus, and then when you are ready, start with the infusion. And also, when we are giving insulin infusion, we have a target. The glycemia should decrease 50 to 70 milligram per deciliter per hour. And if it does not decrease on that values, for example, if it decreases more than 100, we have to half the dose to meet this target. And if it is decrease, if I'm giving 0.1 unit per kg per hour infusion, and after 1 hour, I calculate and I see that my glycemia is not decreasing, we have to double the dose. I think here I'm clear. And also, when the blood glucose go below 200 milligram per deciliter, it is recommended to half the dose of insulin. I mean 0.05 unit per kg per hour, and add that dextrose infusion as I presented on the previous slide. So don't say my glycemia is now below 200, I have to stop insulin. Once I stop the insulin, your patient is not going to move out from DKA. And even they go far and recommend that when the patient is having severe hypoglycemia, like 70 milligram per deciliter, you may be like absent, go somewhere and come, find your patient is having severe hypoglycemia. They don't say stop insulin infusion. They say give that low dose, 0.05 unit per kg per hour, and give a high concentration of dextrose, like dextrose 50%, and keep measuring your glycemia every 1 hour. So it is not good to keep stopping insulin infusion. It is better to decrease the dose of insulin infusion and increase the concentration of dextrose you are giving when you have the hypoglycemia. And I have to go to the other slide. Yes, this slide talks about when to stop the insulin infusion. We stop the insulin infusion when there is a resolution of ketoacidosis, when the anion gap is less than 12, or when beta hydroxybutyrate is less than 0.3. Previously, Dr. Sami presented that in severe DKA, the BHB is more than 3. Now, when it is less than 0.6, you can stop the insulin infusion. This is important because the patient who have renal failure, patient with uremia, even if they are in DKA, the ketoacidosis, the anion gap will not resolve. The anion gap will stay there, but the BHB, the beta hydroxybutyrate, as it is a ketone body, this one will be, the value will decrease. So we will check from the BHB values instead of checking from the anion gap. That you should consider it. And also another criteria, when we control the blood sugar, we stop the insulin infusion when the blood sugar is below 250 milligram per deciliter. And also we need a time of overlap to make sure that in the body there is an adequate insulin. So we overlap the infusion and this sliding scale insulin. They recommend a minimum of 2 to 4 hours overlap before stopping the infusion. Also, it is recommended to stop the infusion when the patient is well eating and also when the acidosis has resolved. We talk on that point. If you have used much normal saline, you will end up being in a non-anion gap metabolic acidosis with a bicarb less than 15 or less, low bicarb values. So we need to give bicarb values to invert our bicarb, and after collecting this acidosis, now you can stop the insulin infusion when all those 5 criteria are well fulfilled. Thank you. Yeah. Any comment from the previous?
Thank you, Dr. Singhi. I put the protocol that that we had talked about in the Q&A, and I'll put it in the chat for everyone as well. But there were many questions about how to do insulin infusions, managing potassium and electrolytes. So we thank you for your great answers.
Thank you, Prof. So the use of sodium bicarbonate in the management of patient who is in a DKA, they say the use of bicarb is not always recommended, but it can help you when the patient is severely acidotic, if your pH below 6.9. So when the pH is below 6.9, one point, our vasopressor will not be working. The patient will be having hypotension. And so by giving this bicarb, can give 100 ml equivalent of sodium bicarbonate in 400 ml normal saline, 0.9%, add some potassium chloride as the bicarb will aggravate the acidosis, and infuse it over 2 hours. And may repeat this dose of bicarb when the pH stays lower. So it is not recommended to give for bicarb for every patient in the acidosis. Also, the bicarb can be used when you are going to do airway management. I said about it. When you have a patient, you have pH 6.9, 6.8, something like that, to minimize that collapse, to minimize the worsening of acidosis during airway management, you can give that bicarb to improve, to prevent that worsening of the acidosis. Yes, thank you. The next. Now, we are going to the point of the complication of DKA, because if this patient who is in DKA or who is in HHS, if we consult the hospital at a late time, for example, the patient consult after 2 days or after 1 day, he will come with severe dehydration, and this patient will end up having prerenal AKI, and the patient may end up having dialysis. Also, this is not only the rate consultation. This AKI may come from us, healthcare providers. If we don't do adequate fluid resuscitation, we may worsen the hypovolemia, and the patient end up having this AKI, acute kidney injury. So AKI is a real complication of the DKA. The other complication, as we discussed, there is this electrolyte imbalance, especially the hypo and the hyperkalemia. As we know, patient of DKA, as we discussed, may come having the hypokalemia. Hypokalemia is an immediate and reversible cause of death. And also hyperkalemia is also a reversible cause of death. So we have to do good potassium supplement controlling to prevent the hyperkalemia, which can kill our patient, but also to prevent also the hypokalemia. The thromboembolism, as a complication of this DKA, the patient who are in DKA or in HHS have hypovolemia, have dehydration. This patient with dehydration, they have increased risk of coagulopathy, and coagulopathy is among the risks of thromboembolism, as we saw on the virtual triad with hypercoagulability, stasis, and the endothelial injury. So we need also to think this as a complication and start the DVT prophylaxis with no contraindication. Hypoglycemia during treatment. So DK HHS management, it is a team effort. It is not a personal effort. By rushing to give insulin, you may end up having hypoglycemia, which is also a reversible cause of death. So also we also need to think about it. Cerebral edema. There is a slide on cerebral edema, but can you go to the slide of cerebral edema? Thank you. The cerebral edema comes when a patient presents in DK or HHS having this severe or hypovolemic shock, and we rush to do rapid or overcollection of fluid deficit. Imagine if you insert like 4 IV line and you start giving like even a 3 to 4 liters per hour, or you see a patient is having hypoglycemia 190, 210, and we start giving hypotonic solution like dextrose 5%, or even you can prepare dextrose 2.5%. If you give hypotonic solution by osmosis, you will end up causing cerebral edema. Among the features of this cerebral edema, the patient will develop altered mental status. The patient presented by Dr. Sami, the GCS improved after fluid resuscitation. But if you do overcollection, or if you use hypotonic solution, the mental status will start to worsen. The GCS will drop again. And also a patient may have headache, seizures. All of those are features of brain herniation, so as a consequence of cerebral edema. I said rapid collection of glucose and large volume hypotonic solution are not indicated to prevent this cerebral edema. The treatment, you just give mannitol or hypertonic saline if you have. In our setting, we have mannitol. Hypertonic saline is not always available. Okay. Previous slide, previous complications, sorry. Yes. Pulmonary edema may occur as a complication also of overfluid collection, and the ARDS may occur as a complication of ventilator-associated lung injury. Also, when the DKA was induced by pneumonia, pneumonia may later complicate into ARDS, or when the DKA was induced by things like pancreatitis, also may end up having ARDS. So those are the complications. Next slide.
May I stop you here, Dr. Singha, before we go on to the stakeholders? We have several questions in the chat, and several of the questions are across very specific themes. So the questions are for all four panelists. How do you manage fluid resuscitation, especially aggressive fluid resuscitation that is required with DKA or HHS in somebody who's presenting with very high blood pressure or hypertensive urgency or emergency? How would you manage that situation with fluids and the high blood pressure?
So the thing I do is I want to do fluid delay. I want to assess the fluid status and see if I can see the heart rate, I can see the urine output, I can do the passive leg raise, I can do the IVC and see how is my patient severely dehydrated. And also, in addition to that, I think of the cause of that hypertensive emergency, because may come from if the patient had ischemic cerebrovascular accident, or if the patient had intracerebral hemorrhage and also present being in DKA. I have to manage the two. So I have to think of the trigger of that DKA and also to assess the real fluid status of the patient, not to give extra amount, but being hypertensive does not come always from that DKA. So I have those two arms. Arm of the cause of that diabetes, of that hypertensive emergency, and the arm of collecting the fluid status. At the same time, patients who have renal failure, patients who have heart failure, all these patients, you need to be like, you need to go slowly. See what's the heart rate, how we adequate assessment of the degree of dehydration. I don't know if I can say about the assessment of the degree of dehydration, but that is really important, not to give extra fluid.
Yeah, this is great. Thank you for that answer. And just to add on to the question and maybe hear from the other three panelists, the most common questions were about fluid resuscitation in high blood pressure, fluid resuscitation in CHF or congestive heart failure, fluid resuscitation with chronic or end-stage kidney disease, and fluid resuscitation with cerebral edema. These are complicated questions with very nuanced answers. that require frequent reassessment. So I'd love to hear from the other three panelists. We'll give Dr. Singh a break and share some of your thoughts about managing aggressive fluid resuscitation with chronic or end-stage renal disease, CHF, hypertensive urgency or emergency, and cerebral edema.
Yeah, that's a great point, Dr. Crawford. And, it really highlights the importance of the monitoring, but also your physical exam and ultrasound, if that's available, to really assess the fluid status of the patient. And one thing, talked a little bit about cerebral edema, but pediatric patients are particularly at risk for developing cerebral edema during treatment of DKA. And, so importantly, measuring, their weight and having a weight-based treatment for pediatrics is really important. So I think really highlighting the importance of someone that has CHF or has another reason for being fluid overloaded, or a tendency to be fluid overloaded, then repeatedly doing a physical exam on them. And that's the same way that you're going to pick up signs of developing cerebral edema and be able to address that.
I agree. I echo similar thought process as Dr. Walker. I tend to use my ultrasound and physical exam quite frequently. And that's why a lot of these patients end up, if it's available, in the ICU, just so that way they can have close monitoring in order to make sure that they're not having complications like cerebral edema, make sure that you're not fluid overloading them, and kind of tailoring your management according to the patient you have in front of you. There's no patient that fits a specific mold, so you just have to see what they're doing and tailor your resuscitation accordingly.
Something that Dr. Singh mentioned I really liked is, when you have these more complex patients, is thinking about how that might have influenced the underlying etiology of triggering the DKA. If you have someone in a hypertensive episode, I thought it was very insightful to think about if you now have an intracranial hemorrhage or some kind of event that then may have triggered the DKA HHS also. I think in general, it's important to remember that the principles will still remain the same. Your index of suspicion for complications and resuscitation and treatment for someone with, especially, CHF is going to be, you have to be on much higher alert and be more astute in your evaluation, but it doesn't change the fact that they're still going to be dehydrated and need to be appropriately resuscitated. Same thing with someone with end-stage renal disease. For these patients, you're going to think ahead already, make sure the patient has appropriate dialysis access, already involved your nephrologists. But I would still make sure that people are aware that it shouldn't diverge from the core principles of treating it. It's just going to change your index of suspicion for potential complications related to their comorbidities.
May I ask one more question from the audience? Are there any special considerations in managing DKA and HHS for pediatric patients? And then the other population would be pregnant women.
I would say when it comes to the pediatric patient, I tend to see cerebral edema more frequent. It's more common in the pediatric age. And so that's something to keep a higher suspicion of when you are resuscitating them, and making sure that not only are you calculating what their free water deficit is, but keeping in consideration what their corrected sodium is for the hyperglycemia that they're experiencing. Because if you're tailoring your resuscitation to that, you can cause very big fluid shifts, and that leads to higher levels of cerebral edema. And I noticed that there were some questions about cerebral edema in this, and you managed it similarly to how you would manage your increased ICP that we talked about yesterday with the TBI lecture. and making sure that you're protecting their airway, you're giving your hypertonic fluids, and so on and so forth, but keeping a high index of suspicion with your pediatric patients for that. And then your fluid resuscitation will be in accordance to their body weight, not necessarily in accordance to what their free water deficit is, just because they're smaller and their physiology is slightly different compared to your adult patients.
Would your
Taking that into
choice
consideration.
would your choice of fluid for resuscitation be different in pediatrics patients?
Typically, they use normal saline in pediatric patients, and a lot of that has to do with the lack of literature for other resuscitative fluids in pediatric patients. Not because it's necessarily superior, but most literature that has been performed in a pediatric population is normal saline, despite the fact that we know what metabolic disturbances can happen with normal saline. They're doing ongoing studies at the moment with lactated ringers and other fluids. And so it preferably would be normal saline just given the literature. But like we've stated before, if that's the only fluid you have, then you should use it. And if you have others available, like lactated ringers and not normal saline, whatever is most available and will resuscitate your patients quickly is what you should use.
Thank you.
And I'll make a comment just for pregnancy cases. You know, some women when they're pregnant, they could be in DKA with a little bit milder hyperglycemia. There's also during pregnancy that can cause some insulin resistance. So pregnant women are at risk of having a new onset diabetes and maybe a little bit more subtle presentation for DKA. And then the treatments, it's important to just treat the pregnant mom because that is what is best for the fetus. So there's not any contraindications for treating DKA in the pregnant mother. If an infection is the cause, then choosing the antibiotics that are appropriate during pregnancy is important. But as far as the fluid and insulin and our potassium and everything, all of those are healthy for the mom, which is the most healthy for the baby as well.
Thank you all. Those are great answers. I'm going to let you go to the next slide, Jado, but just to frame this next few slides, there have been lots of questions from the audience about how to check labs frequently if you don't have them available in resource-constrained or resource-limited settings. How do you mix the fluids? How do you mix the potassium? You know, how do you know what the potassium is if your labs take a long time to come back? So people across the globe in different practice settings face a lot of challenges to make these protocols come together and offer the highest quality access to good care for these conditions. So as you go through the stakeholder slide, I'm wondering if you can elaborate a little bit on that and the challenges that people face.
Thank you. The first challenge we face, I want to come on it. The first one is having a patient in DKA or HHS for 3 to 5 days without improvement. That is common in the developing setting. The one of the reason is either you are not giving adequate fluid resuscitation, either you are not giving adequate dose of insulin, or your infusion pump may not be well functioning. You press the infusion pump, you think it is functioning while it is not functioning. The fourth reason, you may treat the DKA without addressing the underlying cause. If the underlying cause was sepsis, if the underlying cause was MI, if the underlying cause was, so if you don't treat the underlying cause, the DKA will keep recurrent, and we have the patient in DKA for 1 week. So also to mitigate this challenge, I present the slide on these stakeholders. One is to involve the administration. By involving the administration, you inform them how early management and timely management of DKA is associated with a good prognosis. The evidence is that the mortality of DKA in developed setting is lower compared to developing setting. So the administration can be involved for staff education and for availability of diagnostic materials like urine dipstick. It is very cheap and can be used on bedside. Also, in some settings, they allow measuring potassium like 3 to 4 times a day only. Some settings, they don't have ABGs, and they cannot allow you to measure potassium more than 3 times a day. By talking with the administration, they can be flexible and accept. So, and also the training of staff. The other things to cooperate with the laboratory. When you go to them and say, I need this sample, it is emergent, they will give you result in 40 minutes instead of 2 hours or 6 hours. Imagine sending a potassium in the lab and wait the result for 6 hours. It is very bad. The third point is the emergency department. Early recognition, the treatment at emergency will improve the patient and will minimize HDU, ICU admission of a patient with diabetic emergency. Primary care providers are very important because by involving the society, by involving the family, the adherence to medication is good. And also buying medication, people buy medication, people have a good diet, people prevent infections. So family and caregiver management is important. But I can give you, Prof. Anna, as a global doctor, I can tell us more. Thank you.
The reason our team is so fantastic is because we've all made an effort to become global doctors. So Dr. Walker, Dr. Komisky, Dr. Benjamil have a tremendous amount of experience in many different practice settings. As you know, Dr. Singha, I've worked in many places, but my second home is in Rwanda. So everything you've mentioned, I would say the same. Murakoze cyane.
Murakoze. So thank you. That was our presentation.
Thank you so much. The responses that we've received in the chat on the Q&A on the WhatsApp group have sincerely been absolutely overwhelming. We're very, very grateful to all of you. We don't have a poll today, so don't worry about your certificate. One thing I've learned in the last 3 days is people love certificates. So if you were on this session for 45 minutes or more, you will receive a certificate by email. The name on the certificate is the name that you use to register. So if you want to make that correction, please do so. We will do everything we can to add more capacity to the webinars. We were over capacity today, which is actually encouraging. That means there's over 1,000 people from across the globe that want to come together and join this effort to improve the care of critically ill patients. So again, we want to thank you. We want to remind you that that all the materials, the webinar recording, all of the slides, all of the resource library, and we'll soon generate a frequently asked questions document based on the questions we were not able to answer today. All of that can be found on the Learning Resource Center. Additionally, we have been uploading the webinar recordings to YouTube, so we hope to see you there as well. And we hope that you can join us tomorrow for our fourth session of 5. Tomorrow, we will be speaking about septic shock, sepsis and septic shock. So another very high yield topic. So again, thank you very much. I'll keep the chat and Q&A open for another probably 4 or 5 minutes, and we'll see you tomorrow. Thank you very much. And again, thank you to my amazing group of colleagues and panelists, Dr. Komisky, Benjamil, Walker, and Dr. Singha. Murakoze cyane.